Thank you, Dr. Chu, for this introduction. Today, I'm going to talk about percutaneous nephrostomy tube versus retrograde ureteral stent for obstructive uropathy. Objectives that I'm going to go through: history and evolution of percutaneous nephrostomy and retrograde ureteral stent, the impact of both methods on ureter, discuss the role of percutaneous nephrostomy and stent in obstructive urolithiasis, present our preliminary data comparing stent and percutaneous nephrostomy drainage for obstructive urolithiasis, predictors for spontaneous stone passage and complications of both modalities, discuss the role of nephrostomy and stent in malignant ureter obstruction. During the last few decades, percutaneous nephrostomy and ureteric stent have been widely utilized as a measure for temporary or permanent drainage for occluded upper urinary tract. From a historical point of view, the history of ureteric stent goes back to ancient Egypt. The first procedure of ureteric catheterization, which involved insertion of tube inside the urinary system via open bladder surgery, was performed by Gustav Seemann in 1900. The first ureteric stent with an architecture comparable to ones currently used was introduced by Joaquin and Prano in early 1900. Gibbons and colleagues designed a new stent with the distal flange to prevent proximal migration and sharply pointed barbs to prevent distal migration, which became commercially available in 1974. Shortly thereafter, Finney and Herpelin almost simultaneously reported a new stent design to prevent both proximal and distal migration with a G shape that is still known double pigtail or double J stent. Since then, massive technological advancement have had a significant impact on the design and material properties of stent. Each of these developments aim to address a specific failure or cause of morbidity. With here, the novel polymeric stents aim to improve biocompatibility, biodurability, ease of insertion and retrieval, duration of effective dwell time, and cost, all while remaining radiopaque. Metallic stent, investigated more commonly in recent years, attractive as its increased rigidity, led to resistance to compression, which has been utilized more in malignant ureteric obstructions. Biodegradable stents, they are largely at the preclinical stage of development. These stents have been theorized to reduce morbidity associated with the stent removal and sometimes serve as a tool to deliver some drug or medication. Stent coating, research efforts aimed at addressing stent-associated complications such as infections, incrustation, and stent-related pain have focused on alteration of stent characteristics, but most of studies are preclinical and no long-term outcomes available. When it comes to nephrostomy tube, Willard Goodwin in 1955, while he was trying to perform a renal arteriogram, placed a needle into a hydronephrotic kidney and performed the first antegrade nephrostogram to become the first nephrostomy, and then he left the tube to become a first nephrostomy tube. Now I'm going to discuss the impact of stent and nephrostomy tube on ureteric peristalsis. This interesting article was published by Lennon and colleagues in European Urology in 1997. The effects of double pigtail ureteric catheter and percutaneous nephrostomies on ureteric motility and artificial stone transit were assessed in 12 dogs. In eight dogs, each animal underwent initially bilateral nephrostomies, and an artificial solid 3 millimeter steel stone was then inserted into each upper ureter just below the UPJ. A 4 French double J stent was inserted on one side, and that became the group 1, while a percutaneous nephrostomy was left on the contralateral side to become the group 2, and in 4 stone only control ureters became group 3. The nephrostomy was sealed after 72 hours in that group. Stone passage was assessed by plain X-ray. Baseline pelvic and ureteric motility was assessed prior to stone insertion by passage of ureteric catheter via nephrostomy tract sequentially into the pelvic and upper third of the ureter. The catheter was attached to a pressure transducer and a pre-calibrated pen recorder. Measurements were taken over 20-minute period at each location and repeated weeks after. We see here the results. In group 1, the stent group, 1 of 8 stone passed completely, while in group 2, 6 of 8 stones passed completely, which is the nephrostomy tube group, and in control group, all 4 stones passed. We see here this figure showed the normal ureteric motility. And here the diminished motility in G-stented ureter, while preserved peristalsis above distal third of the ureter in percutaneous nephrostomy group. And they concluded that double J stent are associated with ureteric dilatation, diminished peristalsis, and impaired stone passage, while percutaneous nephrostomy preserve ureteric peristalsis and facilitate stone passage. The same group did another study to determine the pathophysiological changes in upper urinary tract motility and calculus transit, which may occur following double J stent insertion. At this time, they studied the acute and chronic effect of double J stent placement. Internal and intra-ureteric pressure and motility were measured in the similar fashion by passing a pressure catheter. In an acute study, the immediate effect of double J stent placement were assessed in 6 adult male dogs. In this group, a 3 mm metallic synthetic calculi were placed bilateral in the upper ureter, following unilateral placement of double J stent in the right ureter. Position of the calculi were checked daily following the initial procedure by QP X-ray. We see the acute effect. They found that raised renal intrapelvic pressure, reduced pelvic and ureteric motility, and delayed calculus transit time, as we see here in this figure. And this QP X-ray even showed the position of the stone in the upper part of the ureter in a stented ureter, while the other side, the non-stented ureter. Chronic study, bilateral double J stent and invalid cannula placement was performed. On day 30, both intra-ureteric pressure and motility were measured. The left double J stent was removed and calculi placed bilaterally 2 centimeters distal to the UPJ. Serial renal pelvic motility measurements were carried out from day 30 up to 12 weeks. At the end of study, segments of ureters were studied in vitro regarding motility, and the remainder of the ureters were preserved for histological examination. We see here the chronic effect showed that intrapelvic pressure had returned to baseline at 1 week following stent insertion. At time of unilateral stent removal on day 30, the ureter were noted to be significantly dilated. After unilateral stent removal, serial QP X-ray performed to show the stone transit time, and it's the same finding that the stented ureter has a significantly longer stone transit time compared to a control group. Histological assessment of the ureter 8 weeks following stent removal showed persistent muscular hypertrophy and collagen deposition in subepithelial layer. The author has recommended that the stent should be removed as soon as it's thought to be safe to do so by the clinician. Now I'm going to present the preliminary data comparing stent and percutaneous nephrostomy drainage for obstructive urolithiasis, predictors for spontaneous stent passage, and complications of both modalities. Retrograde Ureteral Stent and percutaneous nephrostomy tube are considered standard method of urinary drainage. There is currently no evidence supporting the superiority of none of them. The aim of the study was to compare the probability of spontaneous stone passage and its predictor after drainage by both ureteric stent and nephrostomy tube. A total of 298 patients with obstructive urolithiasis were identified retrospectively from 2 tertiary centers in Stockholm, Sweden, from May 2018 to April 2019. The patients were divided into 3 groups. The retrograde ureteric stent group had 104 patients. The percutaneous nephrostomy group had 93 patients, and a spontaneous stone passage group, the control group, had 101 patients. A non-contrast CT was used for initial diagnosis and follow-up until the evidence of spontaneous stone passage or surgical intervention was planned. Following characteristics were assessed: age, gender, BMI, size of stones, location, size, stone density, duration of follow-up, and hospital stay. The primary outcome was to assess the rate of spontaneous stone passage. Secondary outcome complications related to both methods.
So Abdul, these were not patients who were septic then, correct? These were just placed for having obstructing stones and then having subsequent definitive therapy later. Is that correct?
Yeah, but it's we're gonna see the indications. Some of them.
Some of them were septic.
And yes, we can have infection. Okay. We're going to see the indication for drainage later on. Here, the demographic characteristics of the patients. The mean age was highest in nephrostomy tube group, 59.41. Then double J stent group and least in spontaneous stone passage group, with significant difference between groups. BMI showed no differences between the groups. Male were higher than females, with insignificant difference of male and female distribution between the groups. We see the 69.5% of the patients were male and 30.5% were female. Clinical characteristics of patients, previous history of urolithiasis and previous history of urinary tract surgeries showed no significant differences between the groups. Here, the indication for drainage, we see the urinary tract infection was significantly higher in nephrostomy tube group. While pain and high serum creatinine as an indication for drainage were higher in retrograde ureteric stent group, and outflow obstruction, significant hydronephrosis was higher in percutaneous nephrostomy tube group. Side of stone, there was no significant difference between right and left ureteral group. Location of stone in all patients were significantly more in distal ureter, in overall patients, and even in spontaneous stone passage group, 79.2% of the stones were in distal ureters, while in stent and nephrostomy tube groups, the stones were more significantly in proximal ureters. The width, length, surface area, and density of the stones were highest in nephrostomy tube group, then double J stent group, and lastly, spontaneous stone passage group, with significant difference between groups. But this is for the all stones. Here we did adjustment to only past stone. So location of past stone in stent and percutaneous nephrostomy group were significantly more in distal ureter. But we can see here that even a high percent of passed stone in percutaneous nephrostomy tube group, 28.7 in proximal ureter compared to you see the retrograde ureteric stent and spontaneous stone passage group, which is 14 and 13%. Regarding width, length, and surface area, there were no significant differences between the groups, and the stone density was highest in percutaneous nephrostomy tube group, with significant difference between the groups. Spontaneous stone passage rate at the end of follow-up period, we see it was 100% in a control group, followed by nephrostomy tube group 39.8%, and lastly in double J stent group 36.5%, with significant difference between groups. Length of follow-up was highest in double J stent group, then nephrostomy tube groups, and lastly in spontaneous stone passage group with significant difference between groups. Length of hospital stay was highest in nephrostomy tube group, then double J stent group. We see here the complications related to first to both methods. Pain episodes that required healthcare contact and painkillers were significantly higher in stent group, while episode of urinary tract infection after drainage was higher in percutaneous nephrostomy tube group with 28% versus 15.4%. Complication related to ureteric stent, we see here the stone migration upward after placement of retrograde ureteric stent was noticed to be 26%. Complication related to nephrostomy, nephrostomy repositioning or reinsertion in 53.7% in patients with nephrostomy tubes. We see due to a stop or non-functioning nephrostomy in 36 patients, or nephrostomy came out or fell out in 14 patients. To sum up, both ureteric stent and percutaneous nephrostomy drainage appear to be effective. Each modality has its own complications. In our experience, percutaneous nephrostomy drainage can be used in obstructive ureterolysis with the intention of a trial of spontaneous stone passage, especially in frail patients at high risk of surgical intervention, as it showed a high rate of spontaneous stone passage and shorter period of follow-up. Further clinical studies are warranted. When we look at the literature, this study was published by Morris and colleagues. The study aimed to compare both retrograde ureteric stent and percutaneous nephrostomy regarding the probability of spontaneous stone passage and its effect on patients' quality of life. A prospective trial was carried out from July to October 2017. 50 patients were selected with hydronephrosis secondary to ureteral stones, required urgent urinary diversion, and divided into two groups. We see 18 patients in nephrostomy tube group and 32 patients in ureteric stent. The results showed that the rate of spontaneous stone passage was 25% in stent group, while 38.9% in percutaneous nephrostomy group. Percutaneous nephrostomy was associated with a higher rate of spontaneous stone passage when adjusted for stone size and location in comparison with the ureteral stent. Percutaneous nephrostomy was better tolerated with less impact on average quality of life. It has been reported that 30.2% of stones in stent group had an upward displacement. We see here the VAS score, Visual Analog Scale score. No significant difference was found in the median value between the two groups pre-intervention. However, there was a significant difference in the median value before and after urinary diversion in stent group, as we see here. This is a systematic review and meta-analysis conducted by Azoulay and colleagues, included 7 trials, a total of 667 patients. all trials compare percutaneous nephrostomy and retrograde ureteral stent as the intervention and control groups, respectively. Their initial conclusion, they found no difference in two methods in improvement of septic parameters, quality of life, failure rate, post-procedural pain, or analgesic use. However, their conclusion, percutaneous nephrostomy is preferable to ureteral stent because of its reduced impact on patients' postoperative quality of life due to mostly hematuria and dysuria, although it is associated with slightly longer hospitalization duration. This study done by Joshi and colleagues included 34 patients, 21 in a stent group and 31 in a nephrostomy tube group with unilateral obstruction. Each patient completed a questionnaire. They used the Your Quality of Life AQ5D and question to assess pain, urinary symptoms, and day-to-day problems. Their conclusion that patients with double J stent have significantly more irritative urinary symptoms and high chance of local discomfort than patients with nephrostomy. Based on Your Quality of Life analysis, there is no significant difference in gross impact on health-related quality of life. When it comes to quality of life and impact on work, this study demonstrated the impact of double J stent on quality of life, including work. 135 patients with ureteral stent with different indications for drainage, as we see here in the table, whether post-procedure, pregnancy-related hydronephrosis, or stricture. Patients were followed prospectively with an interview and symptom questionnaire completed at 2 weekly intervals until the stents were removed. They conclude that ureteral stent had a significant impact on patients' quality of life. Among working patients, 45% lost at least 2 labor days during the first 14 days, and 32% were still absent from work by day 30. A total of 435 labor days were lost in the first month. When it comes to the long-term or over time effect, this prospective bicentered study over the span of 2 years, 45 patients with double J stent and 30 with percutaneous nephrostomy tubes were recruited. Quality of life assessed by 2 questionnaire, Your Quality of Life AQ5D and tube symptom questionnaire at 2 time points at discharge after drainage and before definitive treatment. The results showed that the 2 techniques had a distinct and significantly different impact on quality of life. However, over time, percutaneous nephrostomy patients' symptom relief and their quality of life improved, while double J stent patient symptom persist. We will look at the table 2 here. We see the tube symptom questionnaire. Urinary discomfort was significantly higher in double J stent group, which even that at the time of discharge after drainage, which persists even until time of definitive treatment. While in a percutaneous nephrostomy tube group, motility was a significant issue, which resolved at the time of definitive treatment. For the quality of life questionnaire, we see here the self-care and usual activities were a significant issue for patients with percutaneous nephrostomy tube, which subsided and disappeared at the time of definitive treatment or became non-significant. Interestingly, the anxiety and depression in patients with double J stent became a significant over time and at the time of definitive treatment. This is a retrospective analysis to confirm the impact of ureteral stent on stone upward migration. 193 patients were retrospectively reviewed, and they found that stone upward displacement occurred in 33.1% after double jet stent insertion. When it comes to the cost, this systematic review included 2 randomized trials, had compared the stent and percutaneous nephrostomy. They found that the cost associated with the retrograde ureteral stent is more than twice for percutaneous nephrostomy for the hospitals. When it comes to the choose of this method of drainage, it's always the surgeon and the central preference, one of the important factors. Here, this study was done in US, a survey of hospital discharge summary in USA of 113,000 patients who had an urgent drainage of upper urinary tract for infection and urolithiasis, found that 87.7% underwent ureteral stenting. While this study was done in UK, a postal questionnaire survey was distributed among 227 urologists and radiologists. 53% of radiologists and 55% of urologists prefer percutaneous nephrostomy to ureteral stenting in patients without coagulopathy, at least in setting of infected hydronephrosis. So the choice of best method of drainage, it's multifactorial. We went through like different aspects, different factors that might be considered before choosing the best method for drainage in obstructive urolithiasis. Now let's talk about the role of nephrostomy tubes and retrograde ureteral stent in malignant ureteric obstructions. Malignant ureterial obstruction usually is associated with advanced cancer. It results from extrinsic compression by a primary lesion, retroperitoneal and pelvic lymphadenopathy, or direct tumor invasion. It's important to know that it's difficult to investigate the effectiveness of different urine diversion methods because of the short and median survival time. The selection of patients with cancer for diversion should take into account factors such as tumor stage, prognosis of primary cancer, likelihood of additional antineoplastic therapy, and quality of life. Appropriate intervention to decompress the upper tract require careful consideration of technical, ethical, and patient's factor. This study was done by human colleagues in Seoul, Korea. The study retrospectively reviewed patients with non-urologic malignancy who underwent ureteral stenting or percutaneous nephrostomy for ureteral obstructions between 2006 and 2014. Of the 778 patients who underwent urinary diversion, we see here the 67.1% underwent ureteral stenting, while 32.9% underwent percutaneous nephrostomy tube insertion. 91% of the patient died, with a median overall survival of 5 months after urinary diversion. The survival rate did not differ between the various types of urinary diversion. Patients who received chemotherapy after urinary diversion had a survival gain of 7 months. They did a universal analysis to assess factors associated with the short survival time, and they found that male sex, previous chemotherapy without radiotherapy, the presence of events related to malignant dissemination, low preoperative GFR, hemoglobin, and albumin levels, and no subsequent treatments, all are associated with short survival times. We see here the type of malignancy. upper GI cancers represented 40%, lower GI cancers 22.6%, gynecologic cancer 23.3%, and others 13.5%. And here we see the overall survival gain in patients receiving chemotherapy compared to non-chemotherapy after drainage. When we always talk about the drainage, especially with the ureteric stent and malignant ureteric obstruction, we are concerned about the failure rate. In vitro model that studied urodynamic flow of urine in a stented ureter, they found that the majority of urinary flow occurs around the stent rather than through its lumen. As an extrinsic compression increases, this is reduced or even stopped, and interluminal flow therefore become even more important. So any mucus or debris collecting on the double jet stent can block this final route of drainage, causing complete obstruction. In order to improve the success of double jet stent in malignant extrinsic obstruction, several groups have tried to analyze the optimum stent properties, and they concluded that the tensile strength is the most important factor. This has led to development of metallic stent, such as Mimocat, which was produced in Denmark, resonance stent from Koch Medical, oleum stent developed in Israel, Juventa in Seoul, Korea. This is the image of Mimocat, resonance stent, and the oleum stent. The failure rate with retrograde ureteric stent in malignant ureteric obstruction in literature has found to be between 16 and 58%. This is a interesting study by Chang and colleagues, 15-year experience with malignant extrinsic ureterial obstruction with indwelling ureterial stent. 101 patients from US, and they found 42 patients had a stent failure at mean time of 11 months, with almost half of these having blocked within the first 6 days of placement. Failure due to a combination of disease process, patient's factor, and the stent itself. So this study by Kiliodenis and colleagues aimed to review literature on the effectiveness, safety, and long-term patency of ureteric niche stents. 31 articles were included in this systematic review, 21 prospective and 10 retrospective studies. The effectiveness of specific mil stent in population studies and comparative studies among different middle stent as well as among middle stent and double J stents. We see here in this table wall stent from Boston Scientific, which is originally a vascular stent. It has a low patency rate, range from 29 to 100%. One of the major complications is tumor obstruction, ingrowth, hemature, and incrustation. Mimocat has a high patency rate, range from 82 to 100%, but one of the major complications is migration, which has been reported to be between 10.8 and 17.4%. Other complications such as infection, bladder irritation, and hematuria have been noticed too. When it was compared to a double J stent, it has been found that patients with double J stent had a higher incidence of urinary frequency, urinary symptoms, and negative view of life compared to patients with Mimocat. Oleum stent has a patency rate between 86.9 and 100%. Major complication was occlusion, but need further studies and documentation to draw a solid conclusion. Juventa has a patency rate between 64.8 and 100%. Complications include pain, secondary migration, but fistula formation has been reported to, whether ureteroarterial fistula, ureteroenteric, ureterovaginal fistula, and control of bleeding. When compared to double J stent, it showed higher patency rate compared to a conventional double J stent at 1, 3, and up to 18 months. So to conclude, both modalities are safe with high success rate. In clinical practice, retrograde ureteric stent associated with more irritative symptoms, hematuria, dysuria, and has negative impact over time. Many factors should be considered when choosing drainage method: patient-specific factors, center preference, and local technical expertise, and even further treatment plan. In case of malignant ureteric obstruction, careful discussion between the patient, their family, and all healthcare professionals involved in the case must be undertaken before any intervention. Thank you, and really appreciate your time. And a special thanks to Dr. Cho for his support and help with this presentation.